Okay, hello everyone. It is our great honor that our work Timing It Right, Balancing Inpatient Congestion versus Readmission Risk has been selected as one of the finalists for the IAAA award. So this is a joint work among myself, Pengyi from Purdue University, and Jonathan Helm from Indiana University, and two great industry collaborators, Jivan and Julian from Lincare Solution Company, who help us to implement the tool from our research in the local hospital. So let's start the presentation from looking at this cover story on one of the recommended magazine for hospitalists and medical interns. So this article started by pointing out one of the most important decisions for hospitalists to make every day is that whether his patient is ready to go home or they should at least stay another day in the hospital. The article keeps on pointing an important trade-off in making this discharge decision. That is, hospital beds are expensive resources, so it's not to the hospital's financial interest to keep the patients unnecessarily long. On the other hand, if they discharge the patients too earlier, they may not fully recover and have to come back to the hospital within a few days, which is known as the readmission. So under the Affordable Care Act, hospitals now suffer penalty if they have an excessively high readmission. So it is imperative for hospital to balance the important trade-off between how long they keep the patient spend in the hospital versus their readmission risk in making their discharge decision. So for this length of stay, we're going to refer it as loss in the rest of the talk. Indeed, many of the literature has found empirical evidence in this trade-off. On a high level, this paper showed that when the hospital more congested, the physician tend to discharge the patients faster. However, a shortened length of stay is associated with increased risk of readmission. On the other hand, literature also shows if the hospital has the capacity to keep patients longer, it does help to reduce the readmission risk. So in this research, our objective is to develop an analytically guided tool for hospital managers to balance this important trade-off in making their discharge decision. More specifically, we want to answer the following two questions. How many patients to discharge and which patient to prioritize for discharging? On a high level, in this work, we develop a data-driven personalized tool to provide actionable information for healthcare practitioners in making their discharge decision. And we successfully implement this tool through the collaboration with Lincare Solution in the local hospital. And our evidence showed that the tool helped reduce the readmission at this hospital by 25%. As estimated from our industry collaborators, this reduction translates into close to $5 million annual saving in the hospital's cost. Moreover, important feedback from the users who use our tool is that this analytically guided tool has greatly alleviated the burden for them to guess which patient to prioritize to discharge. Also, from the patient perspective, a reduced readmission chance greatly improved their outcome and their hospital experience. Furthermore, Jonathan will talk about the broader impact of this tool. Indeed, the tool has been developed and used for the recent surge planning for the COVID-19 preparedness, and he will give more details later. There are three major components in our tool. So we start from the descriptive analytics part. We analyze the patient and hospital level data. We run simple regression and clustering method, which help us to discover first, there indeed is a relationship association between the hospital occupancy and discharge behavior. We also find an interesting phenomenon that there are some patients who are readmitted much earlier than some of the other patients. This descriptive analytics generates important insights, which help us to develop the predictive component. So in this part, we take the individual patient data and translate into a readmission risk prediction. Specifically, we predict the chance and time to readmission for patient as a function of how long they spend in the hospital. Later, we integrate this risk prediction tool into a high-dimensional decision framework and prescribe the optimal discharge decision on who and how many to discharge. Integrating all the three components, we develop a tool and through the help with LinkCare solution, and we have done a pilot implementation in a partner hospital. So in the rest of the talk, I will highlight our contribution in the predictive and the prescriptive parts, and then Jonathan will talk in more details for the pilot implementation. For the predictive part, beyond the standard feature selection, we have met unique challenges in our setting for the prediction tool. The first challenge is that there are way more patients who are not readmitted than the readmissions. So if we directly run a, say, Cox proportional hazard model on this imbalanced data, it will severely bias our estimation. To address this challenge, we develop a two-stage model, where in the first stage, we predict whether the patient is going to be readmitted or not. And in the second stage, we predict the timing of the readmission. We also introduce a mixture component to help capturing the heterogeneity in the readmission timing discovered in the descriptive component. Last, we identify this so-called endogeneity issue between length of stay and the readmission risk from the simple regression analysis. So this issue basically says this issue is basically caused because a sicker patient tends to stay longer in the hospital, and a sicker patient also have a higher chance to be readmitted. So if we run a direct regression, we'll reach the erroneous conclusion that the patient spends longer, their readmission risk is higher. If we use this prediction into our decision framework, we'll get a trivial yet unrealistic solution. That is, we should discharge everyone from day one, since the longer they spend, the readmission risk actually increase. So to address this bias, we borrow the commonly used technique from econometrics, that is introducing an instrumental variable to correct this bias in the length of stay. So after successfully developing this prediction tool, we have find a good predictive accuracy, such as a F1 score, AUC score. More importantly, since our implementation of this prediction tool in the hospital, for one of their important internal metric, which is the positive catch rate, meaning the proportion of patients they can correctly identify and intervene on, this proportion has increased from 44% to 51% after using our tool. This screenshot shows the portal of our discharge planning tool. On the left of the screenshot, you can see different boxes corresponding to different patients that are currently in the hospital, and the number shows their patient's current length of stay. If you click on particular patient, there are additional places allow you to put more information. Clicking the submit button, this will show the predicted readmission risk as a function of how long the patient has spent. Two things worth noting here. The patients are color-coded. This actually coming from a ranking algorithm that I will talk about in the prescriptive component. Also, this recommended length of stay coming from our prescribed optimal number of patients to discharge. So now let me talk about this prescriptive part. So to answer this who and how many to discharge question, we need to formulate our problem into some decision framework. To start, this is the patient flow that is used in our decision. So patients come through the hospital, and our decision is to control or decide how long each individual patient spends in the hospital. After they're discharged, depending on the prediction for each individual's readmission risk, we will know that what's the chance that they're going to be fully recovered and whether they're going to come back to the hospital, and also the probability they're coming back on different days. Comparing to conventional patient flow control problem, we also met unique challenges here in this optimal decision. First, because the prediction analysis depend on highly heterogeneous individual patient profile. We need to account for this heterogeneity in our decision framework. More importantly, since we need to explicitly capture how the readmission risk change as the patient spends longer in the hospital, we cannot use the commonly assumed memoryless assumption for the length of stay. This is gonna be more clear when I show the next picture on the example of a discharge decision dynamic. So here, this basically shows the information that one needs to track before making the decision on a given day. So not only we need to track how many patients are from different kind of patient profile, we also need to track how long they have already spent in the hospital. Then our prescribed decision is how many patients from each of the combination of the patient profile and length of stay to discharge. The chosen patients will leave the hospital at the end of the day. By the end of the day, then those patients who are not chosen to be discharged will stay in the hospital until the next day. Their length of stay will be increased by 1 day. Also, random new patients will show up to the system. As from this dynamic, you can see that we definitely need to track the entire progression of the length of stay. And this is why the dynamic is different from the conventional memoryless coin toss type of decision framework, but we actually have to track all the history. And this historical dependent property make the stay space exponentially large. Indeed, using conventional methods, the largest scale of the problem we can solve is only 2 patient class, and we cap the maximum length of stay as 3 days. Even in this very unrealistic setting, the stay space is huge and take us days to solve this small scale problem. Clearly, it is unrealistic to do with the conventional method if we ever want to implement a tool for real-time usage in the hospital. To address this challenge, we developed a novel approach that transformed this intractable problem into actually very simple univariate optimization problem. The first thing we do is under certain technical condition, we prove rigorously that the optimal discharge action follow a ranking system. So this greatly saved the search over the entire all possible types of combination of patient profile and length of stay when we choose an action. And in the end, when we have the ranking system, we only need to decide on how many patients to discharge, because the ranking will tell us who to discharge once we know how many. Then combining the ranking with a value function approximation, we're able to form this entire optimization problem into a univariate problem, and a linear search is enough. This greatly saves the computational burden. And we also want to note that all this ranking and the linear search are not heuristic. They're developed based on rigorous mathematical analysis, where the details can be found in our paper. Now I'm going to turn it over to Jonathan to talk about the implementation efforts.
Thank you, Pengyi. As mentioned, we, in partnership with Lean Care Solutions, we were able to implement this in a partner hospital. Our implementation followed a 3-phase process. In phase 1, we had to demonstrate the value of the tool compared to their historical discharge practices so that management could make a decision as to whether to proceed or not. After demonstrating this value, we then worked with hospital IT systems to design and launch the tool. And then in phase 3, we engaged in personnel training and patient education as a function of the tool. Okay, so to demonstrate to management that our tool could significantly improve their discharge decision-making and reduce their readmissions, we perform what we call a trace-based simulation, in which we feed in their historical data and compare what our model would have suggested versus what was actually done in practice. From this, we were able to come up with what we call a Pareto Curve, which shows the trade-off between readmission risk and average length of stay, where average length of stay is important to hospitals because each day of the stay is costly and impacts their financials significantly. From this graph, you'll see the red dot is the historical performance, and we can decrease the readmissions from 32% to 28% while maintaining essentially the same length of stay. Or we can reduce the length of stay from about 3.5 days to about 2.6 days, still with slightly lower readmissions. So demonstrating the Pareto dominance of our tool in which you can improve in both directions at the same time. Okay. Now I'm going to talk a little bit about how we integrated our framework with the hospital IT system. Here's how it typically works. At 2 a.m., we get a data dump, which includes admit and discharge information, so we know which patients are currently in the hospital, and also the characteristics of those patients, so we can develop individual risk predictions for each patient currently in the unit of the hospital. This is fed into our cloud-based tool, which then designs the predictions and provides a number of outputs for the discharge decision makers to make appropriate discharge decisions. This is the tool that Pengyi showed earlier. One extra thing I would like to mention about the tool is that upon clicking on a patient, it gives this risk curve as well as a recommendation. And it also, a further click will allow the physician to see why the recommendation was made. So for example, which risk factors were driving the recommended length of stay and the risk curve. This helped gain trust with the physicians so that they could compare their intuition with what the tool was providing and understand that the tool is doing something that matches their clinical expertise. A second factor that we have in here is being able to identify those risk factors for particular patients that may contribute to their readmission. This is used by the discharge planners to educate the patient at the time of discharge as to what features they should be looking out for and things to avoid to help reduce their risk of readmission after they're discharged. Finally, we have an interactive tool for management where they can choose their strategic goals, and it presents a trade-off between readmission risk and length of stay. So if the management has a particular readmission risk target, they're able to see what length of stay would be required to achieve that target. Then they're able to choose which point in this curve they want to be at. And when they select that, it parameterizes the model according to the point that they've chosen. And then that is then delivered back to the physicians. So after our initial proof of value, we performed what we call like a controlled trial, in which half of the patients in a unit, a medical surgical unit, were treated as normal in the controlled experiment, and half of them were part of a treatment group in which they used our tool. Okay, what we did is we measured the 5 most major readmission causing conditions seen here on this axis here, and then we compared the difference between the two groups over a period of about 3 months. As you can see in the control group, the readmissions actually increased for most of these groups, whereas in the group using our tool, the readmissions decreased significantly. Now once we did this control, we then implemented the tool in the hospital, and we compared before and after the implementation and found a 25% reduction in readmissions compared to the prior discharge practices. We also did a comparison month over month because different months have different readmission characteristics. So we compared each month of the implementation with a month from the prior 5 years, with the same month from the prior 5 years, and found an average of a 19% reduction over those months. Okay. So now I'm going to talk a little bit about the broader impacts. Fines and penalties have cost hospitals about $1.5 billion each year. It leads to readmissions lead to poor health outcomes. Patients are sicker at readmissions. There's a major psychological impact on patients that have to get readmitted. And it drastically reduces patient satisfaction in their overall care. Some important facts: 17% of patients are readmitted within 30 days, and 70% are considered preventable. The average cost of a readmission is $14,000 to $19,000, and currently, readmissions, well, in 2015, readmissions cost the US $24 billion. So our original design of these analytics was for daily mini surges in demand, which happen often in hospitals. However, under the COVID-19 pandemic, we see even greater challenges. Health systems are trying to develop surge plans, and one important component of a surge plan is early discharge of patients. Now, our analytics-based tool can help provide decision support for those early discharges and can improve surge capacity with minimal impact on patient welfare, and also even reduce readmissions relative to standard practice, as we saw in our Pareto curve, which then reduces the additional load on the care resources over the course of the pandemic. Currently, we're working with 16 hospitals of the IU health system in helping them prepare for and develop their surge plan for the COVID-19 pandemic. In summary, we created an analytics-based tool for real-time readmission risk prediction that integrates descriptive, predictive, and prescriptive analytics. We've implemented this tool in a partner hospital and have demonstrated significant financial savings and improved patient care and outcomes. Our ongoing work is to further improve prediction accuracy, as well as our work with the COVID-19 pandemic and surge planning with 16 hospitals in Indiana. I'd like to conclude by thanking the competition sponsors, Adelphi University and Canaxis, as well as the competition chairs, Pallav and Juan, and especially our coaches who gave us a lot of valuable feedback in creating this presentation, Maga and Lana. Thank you.